So we're going to start out with a case study. A 32-year-old male traveled to a small village in Mexico and experienced a sudden onset of diarrhea 4 days after his arrival. He complained of nausea, and the stool was watery without gross blood, pus, or mucus, and he had no fever. So things to consider in this case: what's significant about his history? And one of the things that's significant is he got sick 4 days after he went to Mexico. So traveling to Mexico would be a significant history in a patient that has diarrhea. The other point to consider is the lack of fever, mucus, and blood. So remember, diarrhea with mucus and blood is categorized as dysentery. So since he didn't have mucus and blood, this isn't dysentery, it is diarrhea. So components of the gastrointestinal tract. All of the GI tract includes the mouth, the oropharynx, esophagus, stomach, small intestine, which includes the duodenum, jejunum, and ileum, and the large intestine, which includes the cecum, colon. Here's a schematic of the gastrointestinal tract, and also an X-ray of the GI tract. So whenever you're thinking of gastrointestinal infections, you have to consider the anatomy. So you have to think about the acidity and the pH in the gastric cavity, that there's motility there. So you have movement in the stomach and intestines. You have secretory IgA, and you also have your normal flora of the gut, or your commensal organisms that reside in the gastrointestinal tract. And you also have to consider that the role of the commensal flora. So you need those normal flora in your GI tract in order to remain healthy. Diarrheal diseases is the second leading cause of death throughout the world, and there are 25 million enteric infections that occur every year. So GI infection causes significant morbidity and mortality, especially in young children and the elderly. 6 million children die every year from diarrheal diseases, more commonly in parts of Asia and Africa. And keep in mind that most acute diarrheal syndromes are self-limited, so they will go away after maybe a day to 3 days to a week. So they usually are self-limiting, but sometimes they are so severe that you would have to seek professional help, or possibly go on antibiotics, or at least get rehydration therapy. So again, host factors: the stomach has a very low pH, very acid environment. You have your normal peristalsis, that movement that moves food down into the stomach through the small intestine into the large intestine. You have a mucus layer that coats those epithelial cells, those mucosal epithelial cells. They contain numerous cell types. They also have follicles. There's Peyer's patches in the intestinal tract, which is a collection of follicles. And these Peyer's patches have M cells, macrophages, B and T cells, and the secretory IgA. You have your normal flora, and whenever you diminish your normal flora in the GI tract, you have a risk of getting pseudomembranous colitis or antibiotic-associated colitis due to the anaerobic organism Clostridium difficile. You also have to consider personal hygiene and age. So there are certain organisms that are going to be more common in specific age groups. So rotavirus and enteropathogenic E. coli tend to infect young children as opposed to adults. You also have to consider the factors of the bacteria. So does the bacteria produce a toxin such as an enterotoxin, a cytotoxin, a neurotoxin? Do they have the ability to attach, such as adhesins and fimbriae? And do they have the ability to invade into the cell and cause damage? So enterotoxins will alter the epithelial metabolic activity. And what enterotoxins usually do is they cause an accumulation of electrolytes and fluid in the lumen, and this is going to cause a very profuse watery stool, which is categorized as diarrhea. So some enterotoxins are cholera toxin, which is produced by the organism Vibrio cholera, and there's also organisms that will produce a cholera-like toxin. There are numerous tests to detect toxins, but many of these aren't done in a routine clinical laboratory. So a lot of these tests for toxins are sent to a reference laboratory or the state health department, but there are some toxin tests that are done in the clinical labs. Cytotoxins disrupt the structure of the epithelial cells. They are going to destroy those cells, which is going to leave those areas unprotected. So they're going to get rid of cellular secretion and absorption. They're going to damage the tissues. They're going to induce a massive host immune response, an inflammatory response. That inflammation due to the host immune response is going to cause even more damage in that area. So you have PMNs and possibly blood that you would see in the stool. So in the clinical lab, you will do what's called an occult blood, where there's these little cards and there's a spot of stool on the card, and you just put a little drop on, and if it turns a color, you know there's blood present in that stool. Neurotoxins usually are going to, these are something that you're going to ingest in food, so they're pre-formed. This would be a cause of foodborne intoxication. So remember your agents that cause food poisoning. We have Staphylococcus aureus, Bacillus cereus, Clostridium perfringens, and Clostridium botulinum. Out of these organisms, Clostridium botulinum produces a very potent neurotoxin. So clinical manifestations of gastrointestinal tract infection depends on how that pathogen causes disease. So different organisms, different pathogens are going to cause different types of damage. So organisms that upset the fluid balance are going to cause a watery diarrhea. Organisms that lead to cellular destruction are going to cause white blood cells in the stool, diarrhea with mucus and blood, so a dysentery, as well as fever, abdominal cramps, and tenesmus. And tenesmus is straining to defecate. Organisms that penetrate the intestinal mucosa can lead to systemic infection, and then you're going to get more systemic types of symptoms such as headache, fever. The epidemiology of gastrointestinal tract infections. GI tract infections are going to be common in institutional settings such as daycare centers. In daycares, you have a lot of children that are going to be, running around with dirty diapers and sticking their hands in their pants and then picking up toys, and then another kid is going to come over and pick up the toy and put it in his mouth. So daycare centers are a breeding ground for gastrointestinal tract infections. Also, hospitals and nursing homes are at risk for more GI types of infection. Traveling to developing countries is also going to give a person possibly a risk for GI infection. There are more than 12,000 cases of foodborne illness that occur in the U.S. each year, and this is only the reported cases. Many people get some couple of 1 or 2 bouts of diarrhea, or maybe have diarrhea for a day or two, and they never go seek help. They never go to a physician. They never go to a hospital. So these 12,000 cases are those that are actually diagnosed. Individuals that are immunocompromised are going to be at higher risk for getting a gastrointestinal infection, and diarrhea occurs in 30 to 80% of patients that are infected with human immunodeficiency virus. So the common bacterial agents of enteric infection, you have Bacillus cereus, Clostridium species, Staphylococcus aureus, Aeromonas, Campylobacter, Escherichia coli, Salmonella, Shigella, Vibrio, and Yersinia. Also, you don't have to know the viruses and the parasites, but just keep those in the back of your mind because you will have to know them. There are viruses and parasites that cause diarrhea, such as rotavirus, Norwalk virus, the parasite Giardia lamblia, Cryptosporidium parvum, and Entamoeba histolytica. And those are just a few. There's many, many more. For specimen collection, specimens that are delivered to the lab within 1 hour of collection, you can just use a sterile plastic container. So stools sometimes will come in a sterile plastic container, and as long as they get to the lab within 1 hour and are being worked up, that's fine. If there's going to be more than a 2-hour delay from the time the specimen gets collected to its transport to the laboratory, then a transport media such as Carey Blair has to be used because you don't want to lose that pathogen that might be there. If there's a stool that's collected for viral detection, it should be refrigerated. So you remember your viruses are obligately intracellular, so if they're not immediately inoculated into cell culture, the swab needs to stay in the refrigerator. To enhance the recovery of a GI pathogen, many times stools are collected at various times throughout the day and maybe over a period of 2 to 3 days. So you may get more than one stool specimen from the same patient because there are certain bacterial GI organisms that are shed in the stool intermittently. Also, parasites tend to be shed intermittently. So you may need 3 or 4 stools from the same person over a period of time, and only one of those stools may have the organism. So direct detection, we do use wet mounts for GI infection, but that is usually done for parasites, not for bacteria. So a wet mount is not really going to tell you much with bacteria because you have so many bacteria in your intestine. You're going to be thinking, okay, here's a bunch of organisms under the slide. It doesn't really mean anything. But for parasites it does, because each parasite has a very distinct morphology. So you'll do parasitology at the end of the summer. Stains, you can look for bacterial morphology, you can look for white blood cells. I mean, your typical enteric pathogens are gram-negative rods, so you're going to be saying, wow, there's lots of gram-negative rods in here because you have your normal flora like your E. coli and your Klebsiella. So you're going to have so much bacteria that just doing a direct smear and a gram stain is not going to be helpful with a stool specimen. But it will help, again, with parasites. You can detect antigens using fluorescent antibody staining. You can do ELISA techniques, and you could do latex agglutination, as well as some molecular techniques. For culture, stools are usually inoculated onto 5% sheep blood agar, and you always want to use your sheep blood agar so that you could do your oxidase testing. Remember, you never want to do oxidase testing from a selective plate such as MacConkey Agar, because that could cause a false positive oxidase. So you always want to do your oxidase test from a sheep blood agar plate, or you can do one from chocolate agar as well, but we don't usually streak stools onto chocolate. They're streaked onto sheep blood agar, MacConkey agar, and then a more selective media such as EMB agar. So EMB agar is slightly more inhibitive than MacConkey agar. And remember, your MacConkey agar inhibits your gram-positive bacteria, so you can see the gram-negative organisms, and you can also look for lactose fermenters. So MacConkey Agar is both selective and differential. It's a peptone base that contains lactose so that you can see lactose fermentation. It has neutral red that acts as an indicator. When that pH goes down through lactose fermentation, you get a bright pink color. So MacConkey Agar inhibits gram-positive organisms with the addition of bile salts and crystal violet. EMB, or Eosin methylene blue agar, is also both selective and differential. It also differentiates lactose fermenters, so it's a peptone base with both lactose and sucrose. So MacConkey Agar only allows you to see lactose fermentation. EMB allows you to see both lactose and sucrose fermentation. And the indicators in this agar are Eosin and methylene blue, and this agar is a bluish green color. So the common gastrointestinal infections and their agents. The first organism we're going to discuss is Helicobacter. We already talked about this in the spring, so you should already know everything about it. We're just going to do a quick review on these organisms. So Helicobacter, there's only one species, which is pylori. It's associated with peptic ulcers. Remember, it's a very strong urease producer, and the organism needs that urease because that urease breaks down into ammonia, which is going to increase the pH in the stomach. So you can do what's called a breath test to diagnose Helicobacter. You're not actually diagnosing the organism. What you're doing is you're reading ammonia, and if the ammonia levels are above a certain amount, then that is indicative that you have a urease producing Helicobacter present. The more common way to diagnose Helicobacter is through ELISA testing and also possibly through a gastric biopsy. So Helicobacter pylori, remember, it's a gram-negative, can be curved rod, and you can do the breath test to check for ammonia due to that urease production. So Salmonella and Shigella are two big intestinal pathogens. So in order to look for Salmonella and Shigella in the clinical lab, many times stools are inoculated onto either XLD or HE. So XLD and HE agars are great for Salmonella and Shigella because they inhibit most of the Enterobacteriaceae members. So most of our intestinal tract is E. coli and other Enterobacteriaceae members. So if you were to inoculate onto general media, you're going to get a ton of organism. You wouldn't be able to find maybe the smaller numbers of Salmonella or Shigella there. So inoculating onto XLD or HE will help you see a Salmonella or Shigella. So you're going to incubate XLD or HE at 35 to 37 degrees in ambient air. So stools are put in the ambient air incubator. Plates are examined at 24 hours. If you don't see any potential pathogens, They're put back in the ambient air incubator and they're looked at again at 48 hours. There are other selective media specific for Salmonella and Shigella, but these are not as routinely used, but there are labs that may use some of these. One is SS agar, Salmonella Shigella agar. Another is bismuth sulfate, another is deoxycholate, and another is brilliant green. So HE agar, or Hektoen-enteric agar. So the selective ingredients in HE agar are bile salts. They inhibit gram-positive bacteria as well as some of the normal gram-negative intestinal flora. It allows you to differentiate lactose and sucrose fermenters as well as the detection of hydrogen sulfide. So it's differential and selective. It allows you to isolate Salmonella and Shigella from all of those other enteric organisms that are present. It's a peptone-based agar with bile salts, lactose, sucrose, salicin, and ferric ammonium citrate. That's how you see the hydrogen sulfide production. And the indicators that are going to change the color in this agar from a green color to yellow if there's fermentation are bromethymol blue and acid fusion. XLD, or xylose lysine deoxycholate agar, again is selective and differential. It also allows isolation of Salmonella and Shigella from the other normal gram-negative rods. It's a yeast extract. It contains lysine, xylose, lactose, and sucrose, as well as the ferric ammonium citrate so that you could see hydrogen sulfide production. It inhibits gram-positive bacteria with the addition of sodium deoxycholate, and the indicator in this media is phenol red. So XLD, the agar, is a reddish color, and if you ferment, you get a yellow color. So most enterics do ferment xylose, but Shigella doesn't ferment xylose. So your xylose fermenting organisms are yellow because in this agar, that phenol red, when the pH drops due to xylose fermentation, it turns yellow. Shigella doesn't turn yellow, it turns pink. So if you see a pink organism on XLD, you automatically have to think Shigella. What Salmonella does is it ferments xylose, so it would turn yellow, but then it decarboxylates the lysine in the agar, which then could revert back to pink or red colonies. So you have to be careful with Salmonella because you might see yellow, you might see a little bit of yellow and more pink, or you might see all pink. So XLD allows you to detect your hydrogen sulfide production. You want to look for your Salmonella. Salmonella is going to have black centers and usually is going to be a pink colony because of this decarboxylation of the lysine. So we'll start talking about Salmonella, I should say reviewing, because we already talked about Salmonella in the spring semester. So we have 3 species of Salmonella: Enteritidis, Choleraesuis, and Typhi. There are over 1,700 serotypes of Salmonella, so it's very complicated. So we usually just say Salmonella enteritidis because it's Salmonella enteritidis serotype paratyphi, Salmonella enteritidis serotype typhimurium. So it's just Salmonella enteritidis just to make it simple. Salmonella infects both humans and animals, which is why it's considered a zoonotic organism, and it's transmitted through ingestion. The types of infection that Salmonella causes: Enterocolitis, Enteric Fevers, septicemia, as well as asymptomatic carriage. Enterocolitis, what happens is the Salmonella multiplies in both the small and the large intestine. The organisms penetrate the mucosa, which causes a massive inflammatory response. So the infection stays in the intestinal tract. The incubation period is between 4 and 48 hours. Usually people are sick from between 2 to 7 days. The symptoms can include nausea, headache, vomiting, and diarrhea. And it's thought that Salmonella secretes a cholera-like toxin, or it can secrete an enterotoxin. Salmonella also causes enteric fevers, and this is due to the inflammatory reaction in the small intestines. The organism invades the regional lymph nodes. It gets into the lymphatic system and then gets into the blood and organs. So in Salmonella, where you have your enteric fevers, usually there's a rash, which is called rose spots. You have these rose-colored spots on the skin. Symptoms of enteric fever: enlarged spleen, headache, loss of appetite, abdominal pain, weakness, and fever. So there you have your more systemic symptoms as opposed to your intestinal symptoms. Salmonella, classically, you can have a carrier state, and this is usually followed by enteric fever or septicemia. So the organism lodges in the liver. Individuals are asymptomatic, and they can excrete organism in the stool for months to numerous years. And sometimes these individuals require the removal of their gallbladder to try to get rid of some of those organisms. So Salmonella causes salmonellosis. So you can see the hydrogen sulfide production on both HE agar on the left and XLD agar on the right. Our next organism, Shigella, and we have 4 main species: Flexneri, Sonii, Boydii, and Dysenterii. Shigella is non-motile, so that's one of its distinguishing characteristics, because many of our Enterobacteriaceae members are motile. Shigella causes the disease bacillary dysentery. It stays in the intestines. The transmission is fecal-oral, and diarrhea is very severe, can lead to dehydration as well as ulceration of the colon. So what happens with Shigella? You ingest it, it invades the epithelial lining of the intestines. It produces a potent toxin called Shigatoxin, which kills the epithelial cells and inhibits fluid absorption. It causes diarrhea, and it causes an inflammatory response, which then leads to bloody and mucus in the stool, which is your dysentery. So Shigella dysenterii, if you remember, is the most severe species because it produces higher levels of Shigatoxin, and Shigella sonii is the most common species that causes foodborne infection in the United States. And Shigatoxin is such a potent toxin that it is considered an agent of bioterrorism. So Shigella causes shigellosis. It is a late lactose fermenter. So on the left you could see lactose negative on MacConkey Agar of Shigella sonii after 18 hours of inoculation, but after 48 hours of inoculation, Shigella sonii then will start to become pink. So you have to be careful when you look at those stools specimens after the first incubation, which is overnight to 24 hours, you may not see the lactose fermentation of Shigella. You may need to wait 2 days, sometimes 3. So it's a very late lactose fermenter, Shigella sonii is. So Shigella growing on Hektoen-enteric, it's a clear colony, so it is going to look green on Hektoen-enteric agar. Escherichia coli is our next organism, and there are 5 strains: enteropathogenic, toxigenic, invasive, hemorrhagic, and aggregative. So enterohemorrhagic E. coli is also called EHEC. It causes hemorrhagic colitis and hemolytic uremic syndrome. The virulence factors are it produces a Shigella-like toxin, a virotoxin, and it has fimbriae to allow it to adhere to cells. It is involved in foodborne outbreaks, and it causes severe abdominal cramping as well as blood. One way you can find EHEC is to use MacConkey sorbitol agar, which is a selective and differential agar. So instead of lactose, which is normally found in MacConkey agar, MacConkey sorbitol has D-sorbitol as the carbohydrate instead of lactose. So your typical E. coli can ferment the sorbitol, and thus your MacConkey agar, you would see your pink organisms. But E. coli strain 0157H7 cannot ferment sorbitol and is going to be clear on MacConkey agar. So we have E. coli 0157H7 growing on MacConkey agar on the left, and E. coli 0157H7 on sorbitol MacConkey on the right. And you can see on the right with the sorbitol, they're clear colonies, not pink.